from the Karolinska Institute in Sweden about a potential novel risk factor for acute MI. Tell us about the study.
So my background is in rheumatology, and in rheumatology we have for a long time known, especially in lupus where I worked a lot, that the antiphospholipid antibodies are a risk factor for thrombotic event and for cardiovascular events. And now we got the opportunity to reverse the perspective and use the knowledge from rheumatology and apply it to a large study of first-time myocardial infarctions. So we investigated 805 first-time myocardial infarctions that were all less than 75 years old, and 805 gender, region, and age-matched controls. And the findings demonstrate that among the myocardial infarction patients, 11% were positive for IgG antiphospholipid antibodies, which was very surprising to me, but it's a very strong, the association is very strong.
And these are acute MI patients without a history of prior vascular events, so they wouldn't have been classified as
No, and as compared to the controls, maybe I should add that among the controls, 1% were positive. No, they didn't have more venous thrombosis, more strokes, and they couldn't have myocardial infarction in their history. There was no difference.
So this is potentially a new risk factor, a silent risk factor for acute MI. It's hypothesis provoking. What further research questions need to be answered before physicians could start using this, perhaps screening people?
I mean, this is a cross-sectional study, so the samples were taken 6 to 10 weeks after the MI, and we don't know. They could be a reaction to the MI. So the crucial question is, were they there before or at the MI? And so we are now planning to investigate a cohort where we have acute samples and for 3 and 12 months. That's one study that's ongoing. And also, I mean, you could also try to retrieve samples, pre-MI samples, several years before MI, and see if they are there before. And so these are questions that need to be answered, I think, before we can really say how important these antibodies are.
Another question, in your study of the 805 patients, were the MIs more severe or complicated in the patients that had the antibodies?
We did try to look at that, and we couldn't really see a difference. The only difference that we choose not to put in the paper, which is now published, was that there was a tendency, actually it was significant, for more readmissions before the 6 to 10 weeks for those who were positive. But I think the data was not really, we were not really sure that it was appropriate, so we didn't want to put it in the publication. But we are now following up. I mean, these patients were included about 5 years ago, so we are also now following up the long-term prognosis, so we will see if this fraction of 10%, if they have a more severe prognosis in the long term.
That'll be important information.
Yeah.
And in the future, if you establish that these antibodies are present in people before people go on to develop a heart attack, and especially if the MI turns out to be more severe or complicated, how would you picture that changing clinical practice? In primary care, is it feasible for people to be screened, healthy-seeming people to be screened for these antibodies?
I mean, the controls 1% were positive, so I think that's far ahead.
Yeah.
I mean, the first step, if this shows to be important, it would be to screen all myocardial infarctions at the time of infarction, because if they have these antibodies, they're likely to benefit from anticoagulation therapy, long-term anticoagulation therapy. And we've just learned or seeing that the new DOACs and NOACs don't seem to be effective and don't seem to protect these patients from arterial events. So that is also a new information that you need to take into account.
That means they have to go with the old standard, warfarin.
As far as we know now, I know there is a study where they are planning a study where they are planning to use double dose of these new anticoagulants. But as far from what we know now, I would recommend warfarin.
That's kind of disappointing.
But maybe if you're protected,
yes,
it's
exactly.
still better. I mean, it's still better
like,
to be
mechanical heart valves. There was the hope
Yeah,
that DOACs
same.
would be
Yeah,
great,
yeah.
and now verboten. Yeah. Well, this is very interesting. It's thought-provoking work, and we'll follow to see how it turns out.